Hey guys, this is group 3. We are presenting on documentation, referrals, and care coordination. My name is Matthew Nuttall. My group members are Jennifer Belt, JV Raining, and Rebecca Craig. Rebecca?
Okay, so I'm going to take you over the agenda and the overview. Today we're going to talk about documentation processes, referral processes, when to refer out, coordination of care, termination of care, the termination of care best practices, continuation of care, and our case study. And now I'm going to talk about documentation practices. So the purpose of documentation is it's an official record of client progress. So it captures when interventions were used, how the client responded, and any important clinical observations. These records are to ensure continuity of care so that if another counselor or provider needs to step in, they understand where the client is in their treatment history. And documentation also provides supervision and accountability, showing adherence to legal and ethical standards. And as far as best practices and documentation, accuracy is very important. So we need to stick to objective facts, recording only to what was said and not inserting our opinions or our personal judgments in there. Timeliness is also a big important factor. We need to record our notes right after the session to ensure clarity and reliability of the record. And then clinical significance. Treatment planning and coordination of care gives a roadmap for the next steps in therapy. And then it also minimizes the risk of errors, miscommunication, or gaps. So ultimately, good documentation protects the client and the counselor.
Okay, so I'm going to talk about when it's appropriate to refer out. So it's always appropriate to refer out when we're out of our scope of practice or when the client requests it on their own preferences. One of these reasons would be if they needed a higher therapy, like trauma therapy, an eating disorder, or maybe a mental health care. If their assessment shows that they need a different level of care, then we need to go ahead and refer them out so that we are not providing services that does not line up with the level of care that we are providing. If there's a dual relations or a conflict of interest with us, we need to make sure that we keep our professional boundaries and that we do the right thing by them. Um, if you're not seeing any progress in their therapy or what you're currently providing as a counselor, then you need to make sure that you can refer them out of your treatment center. Also, if there's another fit for maybe their cultural needs or spiritual needs or maybe even their language barriers, we need to make sure that we refer them out for those reasons. It does take a team. It takes a big team in order to coordinate care. And when we are working
Next
together,
slide,
we need to
Jen.
make.
Still nothing. There we go. Coordination of care.
Yes, when we're doing the coordination of care, it's really important that we provide a biopsychosocial spiritual therapy to prevent relapse. We got to make sure that we're touching on the mental health professionals. We need to have our psychiatrists, psychologists, and counselors involved. Anytime we need to manage the withdrawal or stabilize medically as far as detox goes, we need to make sure that we're looking into the medical staff and involving all of these people on the team, depending on the level of care they're going to. We also will involve non medical professionals, so case management, vocational training. And so we want to make sure that we have everybody a part of their care. And if we are unable to provide some of these services, we want to make sure that we have these resources with us. Family therapists, I see that quite frequently where my clients and their kids are in my program, and then they have family like a husband or maybe a mom that they're having troubles with, that they need to rebuild those support systems. We do provide family care. Another thing we try to involve people with is like the POs. The POs is a good resource. Sometimes it's Family Recovery Court. Sometimes it's other courts that can actually provide support. And then most importantly, which is really important, is peer support, and then also the admin.
Thanks, Jennifer. Okay, I'm going to go over the termination of care for our clients. Termination occurs when the client has completed their necessary goals for successful treatment. Sometimes we have what's called an AMA, where a client leaves against medical advisement, and that is when they independently choose to discontinue treatment. And other times when termination occurs is when the counselor or other professionals decide that treatment needs to end. When termination is taking place, the clinician must be sure that the client has a healthy transition process. It's very important that we don't just bring our clients into our facility. We give them X amount of days here doing treatment and then just kind of send them out to their old life or send them out to the streets or send them out into an unsafe environment. It's our responsibility and our case manager's responsibility to ensure that our clients have somewhere safe to go when they leave. Okay, best practices for termination of care is very important. That the quality of termination is taken into account. We have to be sure that any significant findings from the clinical staff come to light. We need to be sure that there's a final assessment of the client's condition at the time of discharge so that wherever we are sending them or wherever they are going, let's say it's IOP or sober living, or even potentially to another facility, that we have all the documentation necessary in order to give to that facility or sober living or IOP, so that they have a full understanding of the client that they are receiving. It's also very important to make sure that we have a primary, a secondary diagnosis at the time of discharge so that we can have a full scope of their treatment care. And then continuing care. Important note here, guys, is that when we are intaking a client, that is when we talk about the termination of care, so that the client, when they're coming in at intake, knows what they're kind of signing up for and what they're getting themselves into, so that they can have a vision about what lies ahead. Very important questions that need to be addressed during the continuation of care meeting at the end of termination is: what are the client's conditions and reasons for seeking treatment? How were those conditions treated and resolved? What was the result of those treatment interventions and strategies? What should this client be doing during continuing care? And what type of support does the client continue to need for their ongoing recovery?
Okay, so we have the case study. Julia, she's 26 years old. She's a heterosexual Hispanic female. She's been unemployed and homeless for 5 years. The client has been referred to treatment by Judge Marcus Howard. The client states, "What's left of me to save? There's no Julia anymore, just the drugs." Presenting problem: the client presents with severe methamphetamine dependence, which is marked by a high amount of daily use. She's unstable for her housing, and she has ongoing legal, involvement. History: meth began, or client started using meth about 5 years ago after the loss. She had a stillborn baby. It escalated to daily use, trying to cope, which the daily use contributed to, again, instability, unemployment, housing insecurity, and again, legal issues. So the screeners that we decided to run are the ASAM, which is the Comprehensive Biopsychosocial Assessment to determine the level of care. We also asked the Drug Abuse Screening Test and the SASI-4, which is the Substance Abuse Subtle Screening Inventory. Slide. So we have the DSM criteria. We went through the DSM, and these are the criteria that we feel that the client has met in order to give a recommended diagnosis. The criteria is: use a stimulant in larger amounts and much longer than intended. Spend significant time obtaining, using, and recovering. Artistic desire, but unable to cut down on use. Her social life, work, recreation activities have become lessened because of her use. The diagnosis that we chose to recommend for Julia is a stimulant use disorder, and level is very severe, which is F15-20. We feel that Julia's daily meth use and loss of control have created functional impairment, and her many encounters with the law and its consequences support a 15-20 diagnosis that we chose. The level of care, based on our assessment, we recommend that Julia be referred to a level 3.5 center. We feel that this recommendation is massively appropriate because with Julia, relapse potential, her level of readiness to change, and her co-occurring psychological disorders. And we also feel that medical management is not required.
Next.